Okay, Dr. Ndlovu is going to take us through his oral presentation on coronary Ga-68 Nodagazol PET versus coronary artery calcium scoring in the evaluation of atherosclerotic activity. Thank you.
A very good afternoon to you all. I know it's almost lunch. I'm going to be short. It is a pleasure presenting our work on coronary Ga-68 Nodagazol, which we refer to as ZOL today, versus coronary artery calcium scoring, the evaluation of atherosclerosis. Okay. I have no relevant disclosures, and this will be my presentation outline. So coronary artery disease is a major cause of morbidity and mortality, and its major driver is known to be atherosclerosis. Atherosclerosis by itself, its hallmark is inflammation. So we see here that in patients with persistently elevated low-density lipoprotein cholesterol, should there be a breach in internal or endothelial integrity, there is efflux of the low-density lipoprotein cholesterol and monocytes, which become macrophages, and these monocytes or macrophages, they oxidize the low-density lipoprotein cholesterol to a toxic low-density lipoprotein cholesterol, which is toxic to the macrophages themselves. And this leads to the death of these macrophages, either by apoptosis or by necrosis. And as known, this becomes a nidus for dystrophic calcification, wherein bone-seeking radiotracers can localize. So there are predictors of cardiovascular risk, of which the Framingham risk score is well known, and this is applicable in patients without any clinical manifestations of cardiovascular disease. When a patient has history of cardiovascular disease, REACH and the SMART scores become applicable, but they are limited in the so-called low-risk patient with a limited predictive value. So how can we mitigate for such? The potential solution would be imaging. So there are various imaging probes that target various targets in the pathogenesis of atherosclerosis. The well-known is CT, which looks at the end stage of atherosclerosis, which are the macrocalcifications. But as we know now that there is a concept of the vulnerable plaque, which is prone to rupture, causing the major coronary artery events. So we see that with inflammation, fluorine-18 FDG targets inflammation. Other tracers that have been used to target inflammation atherosclerosis include somatostatin receptor imaging agents, Ga-68 pentaxy-4 localizing in the CXCR4 receptor in macrophages has been used. But more importantly today, we are going to focus on the imaging of microcalcifications, of which the commonly used has been fluorine-18 sodium fluoride. In our case, we decided to use ZOL. So, just a recap on how CT does risk stratification. It looks at the coronary artery calcification and the severity of the obstructive coronary stenosis. And the coronary artery calcium scoring is a robust tool for cardiovascular risk stratification and prognostication, but it has a limited predictive value, as we stated earlier, that it looks at the macrocalcifications, which are more stable, whereas it may miss the microcalcifications, which are associated with vulnerable plaques. So this brings about a growing interest in novel risk stratification methods that allow to assess the atherosclerotic activity. As stated earlier, fluorine-18 sodium fluoride, a bisphosphonate, has been evaluated, and it has been found to predict as a predictor of future myocardial events in patients with non-coronary artery disease. So in our setting, we aimed to use Ga-68 Nodagazol. The reasons being, Ga-68, we obtain it from an in-house generator. It is readily available to us, but the mechanism of localization with the two remains the same. So we have used Ga-68 Nodagazol in the evaluation of bone metastasis in prostate cancer. We also demonstrated that it localizes in dysregulated calcium homeostasis in acute myocardial infarction, and we also correlated the uptake of Ga-68 Nodagazol in that its uptake correlates with the cardiovascular risk profile of patients. But there is no study that has evaluated it as a predictor of future myocardial events or correlated to the calcium score. So our aims were to establish the relationship between ZOL uptake and the coronary artery calcium score, and to correlate the two with long-term cardiovascular outcomes. So in terms of uptake, we correlate the uptake, we quantified it as the SUV max and the TPR max. More importantly, the TPR max as per the consensus of the EANM on imaging of atherosclerosis. And the long-term outcomes that we looked at were fatal or non-fatal myocardial infarction. So these patients that were known with coronary artery disease, we have reviewed their records, did cardiac CT and PET CT within a week of each other, in-house labeling of Ga-68 Nodagazol, and imaging was done 60 minutes post-injection. We quantified the calcium score in the respective vessels, the SUV max, the TPR max, and we followed these patients for non-fatal and fatal or new onset angina. The majority of our patients were male, with 12 out of the 18 that we evaluated having an adverse event, and mostly these patients had hypertension, diabetes, smoking, and mostly with BMI of over 25. And these are the mean and ranges for the calcium score, SUV max, and the TPR max. So in the results, we demonstrated that the coronary artery calcium score correlates to ZOL uptake, and we also demonstrated that the calcium score correlates to the cardiovascular outcome, together with the ZOL uptake based on TPR and the SUV max, which is not shown here. We see that this is a case of a 75-year-old male patient with multiple cardiovascular risk factors, high calcium score of over 2,000, and the highest TPR max was 1.73, and the SUV max was 2.00. Whereas we also see that this patient, the high calcium score and a TPR max of more than 3 had a fatal event, a myocardial infarction at 8 months, whereas the previous one had a non-fatal myocardial event at 23 months. So this demonstrates that despite the fact that these patients had comparable calcium scores, the ZOL uptake was more of a predictor of the outcome compared to the calcium score. So in summary, we evaluated the ZOL uptake and compared it to, we correlated to calcium score and cardiovascular outcome, and we noted that its uptake correlates to both the coronary artery calcium score and the long-term cardiovascular outcome in patients with established coronary artery disease. So our findings were similar to those and were comparable to those that were done with the fluorine-18 sodium fluoride, but in our case, we note that the group that used fluorine-18 sodium fluoride quantified the total coronary microcalcification activity. This requires specialized softwares, which would be more important because it quantifies the wall vessel microcalcifications. In our case, we looked at the most intense blood vessel, which we presumed was the most vulnerable plaque. But the strength of our study is that ZOL is available. You can label it whenever, whatever time. Although Ga-68 Nodagazol, the limitation was that Ga-68 Nodagazol, the resolution would be lower than that of fluorine-18, and we had fewer patients, and we recommend that they should be multi-center studies that would recruit multiple patients so that we can also compare this with the REACH and the SMART scores. In conclusion, in this cohort of our patients with non-coronary artery disease, we demonstrated a strong positive correlation between the coronary artery calcium score and the level of ZOL uptake in atherosclerotic plaques. And in addition, both the coronary artery score and the level of ZOL uptake have strong predictive value to the long-term cardiovascular outcome. So this, in general, this study demonstrates that ZOL uptake, the level of ZOL uptake as a predictor of long-term outcome may help know which patients you need to intensify therapy and those that you need to de-escalate therapy. Just to acknowledge the colleagues who were instrumental in the success of this study and the team which gives support day and night. Thank you for your attention.
Thank you so much, Dr. Ndlovu. I certainly liked your abstract a lot, and I wish we had more time to delve into it perhaps at a later stage. If anyone wants to approach any of our speakers, they're most welcome to do so on this side.